Well, good afternoon, everyone. It's June 18th, Thursday, a beautiful day. Welcome to our webinar for Ask the Dementia Expert. I'm Wendy Askew now. I welcome you all to attend our Johns Hopkins Enhancement Program. We're pleased to provide professional development and community education in our monthly Lunch and Learns. This is year 2 and month 6. So we welcome you to our Ask the Expert. If you're new to us and joining us for the first time, we do have our other recorded sessions as well as resources available on our website where you registered. You can scroll down to the bottom of the page and pick and pull out what is a good fit for you if you have educational needs that you're looking to address. I'm with Jane Marks, RN and MS. She's the lead WEP educator, nurse, Division of Geriatric Medicine and Gerontology, and she will be introducing our guest speaker today. I do want you to make note of next month. We have a save the date of July the 16th. We will be introducing the GUIDE program, which is a CMS model guiding an improved dementia experience, and have a variety of speakers across the state that are implementing GUIDE services in Maryland. So we hope you save the date for that and register for that event. I am going to introduce Jane now, and I'm going to allow Dr. Aniki to share.
Okay, well, thank you, Wendy, and welcome everyone. We're excited to have Dr. Aniki present today the late syndrome. Dr. Aniki is Associate Professor at Johns Hopkins School of Medicine in Psychiatry and Behavioral Sciences. He's also the director of the Frontal Temporal Dementia Program, as well as the director of Young Onset Dementia. He is a specialist in neuropsychiatry and focuses on the diagnosis and care of neurodegenerative diseases that develop in midlife or earlier. He also engages in research that's focused on the epidemiology and treatment of frontotemporal dementias, Alzheimer's disease, Lewy body disease, and other neurodegenerative disorders. So it gives me great pleasure to have him come and talk about late, which is something new that we're learning about. So thank you so much for taking your time and sharing your expertise.
So thank you so much, Jane, for the introduction and for the invitation as well. Thank you, Wendy, as well, for helping to set this up. I will be and thank you everyone for coming and being interested in this topic. I am going to be talking about what we call limbic-predominant age-related TDP-43 encephalopathy. It's a mouthful. But it has an apt acronym, which is LATE. What I will do, just realize that I don't. What I'm going to do is, describe to you what this acronym, what this condition is, what the features are that define it, as well as the important clinical features, neuropsychological profiles that might suggest that you consider it either in place of or alongside Alzheimer's disease. And there are some diagnostic tests that are helpful when you're confronted with a patient and you're thinking about late, or results that might lead you to suspect it. And the idea would be to be able to identify it, or at least if you have the suspicion, to refer to people who can then provide the care. And we'll talk a bit about what kinds of care makes sense for late. The late, to some of us is what we used to call hippocampal sclerosis. And historically, hippocampal sclerosis was defined neuropathologically. It was confirmed neuropathologically. It was not a condition that had a sufficiently distinct clinical syndrome to allow us to separate it in life from Alzheimer's disease. Also, we didn't have the biomarkers then that we have now. It has historically, when people assembled population-based cohorts, of Alzheimer's disease, like in the Honolulu aging study, the Baltimore aging study. There are others around the country and around the world. It was not uncommon to find about roughly 12 to 15% of those who came to autopsy. It was not uncommon to find them having focal atrophy in the hippocampal areas of the brain, which are parts of the temporal lobes, and to find that those people, when you examine those areas, they had focal hippocampal sclerosis, when you examined it microscopically, you found neuronal loss in certain layers of the hippocampus. And starting from about 2000, the mid 2000s, 20,000s, when we now had the ability to stain for TDP43, we now discover that a substantial proportion of these people had TDP43 positive inclusion bodies in the neuronal cells in the dentate gyrus layer of the hippocampus. So these cases were distinct from Alzheimer's disease in that they were amyloid and tau negative, as I mentioned, TDP43 inclusion bodies in the hippocampal and entorhinal cortices, and focal atrophy of the limbic cortex, specifically the temporal cortex, but in some cases, in the more advanced cases, also involve extending into the inferior frontal areas. Now, in large community-based series, it now would appear that there are up to 20 to 45% of elders who are older than 80. So when you use 80 as the age cutoff, then the frequency of this state rises to close to 50% in some cases. And it may occur with Alzheimer's pathology. So reasoning backwards from the old hippocampal sclerosis from today's late, what we see is an amnestic syndrome. So when you go back to the clinical data, you find an amnestic dementia syndrome that is typically manifest in the oldest old, meaning people 80 and older. It's a circumscribed amnestic syndrome. So unlike Alzheimer's disease, many of these people have only memory loss. They don't have disorientation. They don't necessarily have confusion. They may have relatively preserved reasoning. It's usually indolent, and by that we mean that the decline is much slower than is typical for Alzheimer's disease, which perhaps is part of the reason why they appear to have good orientation, good reasoning. And so life expectancy typically exceeds 10 years. Now, there is now a formal definition, neuropathologically based definition of late and a staging to go with it. So what you see in panel A, so one shows, it basically shows sections through the amygdala, the entorhinal cortex, and the inferior frontal area. So these sections in these areas are used to define it neuropathologically. And so these are subjected to examination. And what you can see here in panel 1 is the amygdala. In panel 2, you can see the hippocampus region. And so this is the amygdala right here. This is the hippocampus. And there you see the middle frontal gyrus. And that would be the inferior frontal gyrus, this area. And so B and C show you how pathology is sort of distributed and defined. So at stage 1A, the earliest stage would be pathology constrained to the amygdala. And people have lately, and typically, historically, and even in contemporary examinations, you usually don't observe pathology in the hippocampus without pathology in the amygdala, but occasionally it happens. Typically, it's amygdala alone or amygdala and hippocampus. And when it's amygdala and hippocampus, that's stage 2. But there are a minority of cases with pathology isolated to the hippocampus, and those are called stage 1B. See, in stage 3, it has spread to the medial frontal gyrus, to the inferior and middle frontal gyruses. But the medial frontal gyrus pathology is what is used to define staging. Panels D through H basically show you the different morphological characteristics that these inclusion bodies can take microscopically. So they could look like tangles, except that they stain positive for TDP43 and not for tau. They could be granular and sort of like cotton wool, what we sometimes call skein-like. They could also have different other kinds of like curved morphologies, rounded morphology. They could look like neurites, broken up cellular processes, so like strands, if you will, threads. That's what you see in panel G. And sometimes you might observe them in the glial cells rather than or in the process of the glial cells rather than in the neurons themselves. Now, just to take a step back, so the contemporary classification of Alzheimer's disease has similar characteristics. I just showed you that late is defined pathologically and also clinically. And in fact, you can have the pathology in advance of having clinical syndrome, similar to what we are now discussing and similar to contemporary considerations for Alzheimer's disease. So this is an illustration of the same idea, but for Alzheimer's disease. So you can have pathological change, which would be preclinical AD, with no clinical symptoms. So you have pathological change with no clinical symptoms. We'll call that preclinical. And then you have what is called mild cognitive impairment, which I think all here, or at least most, will be familiar with, which is to say that someone has a smattering of impairments, typically beginning with memory, but not always, but not rising to a level that impairs function sufficiently for us to say the person has dementia. And then eventually it moves to dementia and then moves through the stages of dementia. And the pathological state itself advances as well. And so you have this complicated staging system. Now so you can have both pathologies late, in these older people with late may have Alzheimer's disease, they may not, so they can coexist. And because the clinical syndromes for either one are very similar, it can become very difficult. It is very difficult to distinguish late when people are, in life. So when you have a patient, an elder in front of you, if they're 80 or older, and they have amnesia but seem to be well-oriented, seem not to be confused, seem to be able to reason at a high level, then that might be someone you might suspect has late. Now, if they're quite disoriented, have aphasia, meaning language difficulty, have apraxia, then you would suspect Alzheimer's disease. So the core clinical features of late. So when we think late is the primary driver of the amnestic syndrome, we would anticipate, on MRI that they would have significant focal atrophy, that this atrophy will be focal, will be localized to the hippocampal areas. And if amyloid biomarkers, now we can do an amyloid PET scan. You could also look at tau 181, preferably tau 217, as well as amyloid peptides in the blood. But if you don't have access to that, then at this point you would probably say this is possible late. So this is a formalized classification that our work group they've published last year. Now, if you do have access to this testing, if you do the testing and the results are not negative, meaning they're not consistent with Alzheimer's disease. So that means you're sending the person for blood testing, for CSF analysis, or for amyloid PET. So if any of this, whichever you choose, comes back negative, then it's probable late because you've discounted Alzheimer's disease. If, on the other hand, it's amyloid positive, people now suggest that you then do tau biomarkers. In this case, it'll be the tau PET scan. And if the tau PET scan is negative, then we would still say possible late, with maybe a smattering of Alzheimer's pathology. If it is positive, then the formulation is that this is either Alzheimer's disease or it's Alzheimer's disease with late. Now, if the features are consistent with AD and they're amyloid and tau positive, then you're likely dealing with Alzheimer's disease. But there are some features that might suggest that there's concomitant late. For example, if there's severe hippocampal atrophy out of proportion to the severity of dementia. or out of proportion to the degree of tau pathology that is demonstrated. Or if the FDG PET scan shows low tracer uptake in the inferior temporal area. So this is getting rather sophisticated, and in most clinical situations, I think once amyloid biomarkers are positive, most people are going to conclude that this is Alzheimer's disease. And it's not yet established to what extent there'll be value in determining to what extent there's late contributing when you're confident that Alzheimer's disease is present. So that's still work in progress. But what we do know is that pathology is that the clinical progression is worst when you have late and Alzheimer's disease together compared to when you have late alone. So if you look at these graphs, the graphs on your left, first of all, you can see looking at the different cognitive measures. So one is the MMSE, which is a bedside composite measure. And then you have other measures that are specific to particular domains of cognition. And what you can see here, so this is probable late, this dark line. Orange signifies possible late with AD. And the red line is AD, and then this other line here is possible late. So what you can see is that when it's clearly late, progression is much less severe than when late and AD are combined. And late and AD together are worse than AD alone. And that is shown consistently through virtually all of the panels. The exception would be for memory. So when you're considering memory specifically, then then the clinical change in memory score and the clinical change in probable lates in the memory's change in probable late are comparable. But in other domains of cognition, probable late is better than late, and it is better than AD, and it's better than the combination of late and AD. Now let's look at panel B. These are survival curves. And what they essentially show you is the same thing, but measured in terms of cognitive decline and survival probability. Again, demonstrating that survival is best with late. So it's about 50% survival at 10 years, compared to, close to roughly just over 25% for AD, and much lower, less than 25% when it's late plus AD. So the significance of the combination is that the prognosis would be worse than would be expected for either AD alone, and certainly compared to late, which has a relatively, as I mentioned in the beginning, a relatively indolent course. Let's see how this looks. Let's bring this back to the clinic and to where we can start to think practically. So panel A, which is this one here, you have an elder, a 90-year-old, who has had amnesia for 8 years that has progressed, and a mild decline lately in category fluency. And you can see the severe hippocampal atrophy. And that's shown by the arrows. The amyloid PET scan here was negative, and an autopsy showed him to have stage 3 late neuropathologic change, which basically means he had pathologic change in the amygdala, the hippocampus, and the medial frontal lobe, medial frontal gyrus. So he had hippocampal sclerosis, which is essentially hippocampal atrophy, and very low Alzheimer's disease neuropathologic change. So some amyloid, but no tau. And that's the formal staging there. Now, the next panel is an 86-year-old who had 2 to 3 years of progressive amnesia. And he had severe hippocampal atrophy, which you can see. This is magnified. Um, and severe cortical thinning, which is right here in the entorhinal cortex. The amygdala PET scan was, sorry, the amyloid PET scan was negative. So this one, it was probable late. And here is FDG PET seeking to make the same interpretation. So you have severe hypometabolism in the medial temporal lobes with sparing of the medial of the lateral temporal cortex left. So this is late. And this is contrasted with the pattern for Alzheimer's disease, where you have milder medial temporal hypometabolism, which is here. So you have worse hypometabolism in the middle, in the medial temporal areas in late, with relative preservation of activity and the lateral temporal lobes. And you have the reverse for Alzheimer's disease, where there's more pronounced hypometabolism, essentially in the lateral aspects of the temporal lobe. So this is one way in which you can make this distinction. In practice, it's not always easy to do. So biomarkers for differential diagnosis. ApoE4 is more strongly linked to AD risk than it is to the risk for late, although there are some linkages to risk for late. It's useful for evaluating the risk of anti-amyloid treatment, so that would be its clinical application today. It doesn't have particular diagnostic value. We've talked about amyloid PET and tau PET. Where they are positive, those would indicate AD. Where they're negative, they would indicate late in the right clinical setting. Sometimes you can have a positive amyloid PET when there's Alzheimer's disease neuropathologic change in association with late, but you would expect tau PET to be negative. Now, if you're looking at amyloid beta 42 or 40 in the CSF or in the blood, you would expect these to be diminished in AD and normal in late. And you would expect an elevation of total tau and p-tau in the CSF in AD, but not in late. In late, these indices will be normal. So basically, normal diminished amyloid, whether in CSF or blood, suggests, or elevated tau suggests Alzheimer's disease. Normal results suggest late. If you have an amnesic syndrome in an elder at very advanced age. Neurofilament light chain, people have talked about this as a marker of neurodegeneration. It's not specific to any particular neurodegenerative condition. And it's also unreliable. You know, we have had patients with, and this is also reported in literature, we've seen patients with flagrant dementia who have normal neurofilament light chain levels. We also know that chronic renal failure, for example, can cause neurofilament levels to be elevated. Generally, NFL will be normal in psychiatric patients. So if your question is about a psychiatric state versus a dementia, it may help you think, getting a normal value may encourage you to think that this could be psychiatric, but the caution is that it's not uncommon for it to be normal when dementia is obvious. So we don't rely on it diagnostically. But it can add to the evidence if everything else is normal, particularly PET scan, an FDG PET scan. So the care for late is multifaceted, as it is for Alzheimer's disease, as it is for the other neurodegenerative conditions. I think important considerations are that late, as I mentioned, is indolent. So it typically follows a very slowly progressive course unless it's occurring alongside Alzheimer's disease change. So anti-amyloid therapy should only be considered if you can establish, firstly, that Alzheimer's disease is present, and secondly, that Alzheimer's disease pathology, I mean, Alzheimer's disease is contributing significantly to the clinical syndrome. If you believe that Alzheimer's disease neuropathologic change might be present, so if amyloid is positive but tau is negative, and the case is very mild and indolent, that's a situation where anti-amyloid therapy would be questionable. We wouldn't recommend pursuing it because our conclusion would be that is late with some Alzheimer's disease related change, but not Alzheimer's disease pathology. So care is, of course, individualized as it is for every case. Right now, we don't have any curative interventions. Focus is on prevention, and that mostly today centers on lifestyle interventions. I think we're all familiar with exercise, mindful diet that's low in carbohydrates, low in polysaturated fats. So ameliorative care would be essentially things like cholinesterase inhibitors and medicines that manage the psychiatric states that can complicate things. And rehabilitative care would be the various interventions designed to support or enhance quality of life or functional performance. So these would be things like physiotherapy, occupational therapy, care skills programs, and so on. And there are palliative interventions as well, particularly for advanced cases, and those are essentially targeted at improving quality of life where there's not really an expectation of amelioration or rehabilitation. And I think these are the kinds of interventions I would expect that everyone here is familiar with. What does the future hold for understanding late? Firstly, it would be really helpful to have TDP-43 specific biomarkers, and that way we can directly establish the diagnosis or refute it. And it will be easier to make decisions regarding the relative contributions of late and Alzheimer's disease. Also, or for that matter, some other condition that might co-occur with late, like Lewy body disease. It'll be easier to make these attributions regarding severity pathology if we had TDP-43 specific biomarkers that were also had some degree of had strong correlation with illness severity, meaning that the levels rose in a predictable manner according to how severe the illness is. So we need them for diagnosis where they don't necessarily have to have correlation with severity, you just have to have correlation with status. And we need them for monitoring, and those kinds of biomarkers will need to travel with severity. Some people have argued that quantitative MRI and FDG PET measurements will be helpful. So having ratios, having specific degrees of atrophy or hypometabolism, or ratios of hypometabolism in one area versus another, or atrophy in one area versus another. I'm less certain about the extent to which quantitative measures may contribute, except to say that in the very earliest stages, they might improve sensitivity. There may be value in being able to predict stage and progression based on clinical and biomarker. That is to say, when you have a patient in front of you, being able to give patients and families some understanding of what is to be expected, say in the coming months or in the coming year, that can be useful data for guiding care. We would like to refine our understanding of the correlates and the things that contribute the risk factors for late. There's very little information about the risk factors for late. And so that's a big gap. And then we really don't know to what extent how late varies according to demographic or ethnocultural background. Is it equally distributed across different ethnocultural groups or not? That is unclear. And if there's uneven distribution, is that due to biological factors or due to lifestyle factors? That too, we don't know. And we don't know anything about genetic risk factors either. So this will be important things to understand if we're to make headway with prevention. And then we'd like to understand what specifically is the interaction between late and amyloid pathology or amyloid and tau pathology? Because as I showed you, when Alzheimer's disease and late co-occur, progression is much worse. So there's an interest in understanding how these pathologies interact. Ultimately, all of this information is intended to funnel into preventive strategies and into treatment strategies and into curative strategies. So in other words, into treatment development. So I'll stop there. These are my acknowledgements. And as you know, very few good things are done alone. All of us rely on collaborations and help us to do the work. And so I acknowledge them. Thank you. I'll take your questions now.
Thank you so much. A lot of information. Sounds like a lot more research is coming down the pike too to help us better understand, which is good.
Yes.
Um, I guess, in listening to what you're saying, I see one of the biggest asset of diagnosis is, as you mentioned, in that late doesn't progress as you would see in a typical Alzheimer's patient. And so therefore it would help our caregivers plan for the future in that it may be a different trajectory than what our regular Alzheimer's patients will have. And therefore maybe help them in guiding, their interventions and planning and so forth is, I think, one of the key points that I'm taking away. And I think the other key point is, again, getting back to that healthy diet, exercise, social connections. All of those things are still relevant in late, just as well as what we've identified in dementia overall. Am I correct in assuming there are two good points that I'm thinking?
Absolutely, absolutely. Yes, and I'm sure you know this. Many people here probably do as well. That a lot of dementia care is outside of the traditional healthcare reimbursement model, and so a lot of this is out of pocket cost. Residential care, daycare, these are big considerations. And we often are faced with the question, what is the appropriate timing for residential care? What is the financial forecast? So when you know you have an indolent condition where the likelihood, for example, of behavioral dysfunctions and the kinds of decline that might force residential care are low, it makes the financial forecast easier to work with because you have more time and the higher likelihood that residential care placement will be relevant. So that's very important information for people to have as they plan, as they count their pennies. And then, with the lifestyle modifications, the heart of that message is that we're talking not necessarily about modifying neurodegenerative pathology, but rather we're talking about optimizing brain health. And we're reminding ourselves that, the brain has needs, we can't see our brains, everyone can see their bodies. So you can tell when you might be worried about being overweight or underweight, but it's harder to appreciate that for the brain. So it's an important message to continue to drive home that there are specific actions that can be undertaken to optimize brain health. The idea being to maximize the resilience of the brain to neurodegenerative change from whatever quarter that change might come.
Thank you. Does anyone else in the audience have a question or would like to bring up a point that perhaps they're questioning or thinking about? We're happy to take questions. I think you can unmute yourself. Is that right, Wendy?
Yes, everyone can unmute themselves or put your question in the chat.
So I'm not seeing anything. Oh, wait a minute. Cheryl raised her hand.
Hi.
Hi, Cheryl.
Um, You see me here.
Yes.
Thank you. This is really interesting. This is a more general question. It's not specific to late. So if you have late questions, you should answer those first. But my question is, to what extent is it helpful to tell a person with early stage? I think my mom is stage 1, according to your little chart, and who knows what it is, but she's 90. To tell them that they have dementia or Alzheimer's disease versus not to tell them. And I understand that that's going to be specific to different people, but I'm curious what people's opinion is on that.
In general, my position is that disclosure is best, because especially if it's someone who is still able to participate in care, they can then begin to learn what they need to learn and begin to participate in either to adjust their lifestyles and other things in order to optimize in order to improve their prospects, to engage effectively in treatment. But also because can be very difficult for relatives, especially as things advance, to provide care if they're tiptoeing around what is actually going on. It's very difficult to say you want to help someone, and when they ask you, when they say nothing is wrong with me, you say, I know, but I still want to help. And it can become very awkward. And so this whole business of walking on eggshells when you're trying to provide care can be removed. The awkwardness and the stiltedness of the communications you have to engage in to work with someone can also be removed if everything is on the table, if the family is liberated to be able to speak frankly. Now, that, of course, may result in conflict, but I think in general, when people have good faith, conflicts usually promotes clarity, understanding. And if you're engaged in conflict with good faith, it's because you want to help and you identify a problem you want to resolve. And typically that means there will be a resolution that is honest.
Okay. Thank you very much. That's helpful.
Thank you, Cheryl. I think we had another hand raised.
Hi, yes. Thank you so much for this. I heard you mention ruling out psychiatric illnesses for patients, but I'm wondering if there's studies that, patients who have schizophrenia or other like thought disorders that can present sometimes similarly, or forgetfulness, things like that. If there's any studies between how to differentiate between an aging adult with schizophrenia already also acquiring dementia or Alzheimer's. Is that something that has been studied?
That's an exceptional question. Firstly, there's old literature describing progressive cognitive decline, as people enter late life with schizophrenia, or as people enter late life with bipolar disorder. So I think the literature is clearest on those two. And when people have had autopsy series, particularly bipolar disorder, they don't find pathology consistent with any specific neurodegenerative disease. And so some of the theories include things like neuronal burnout from a lifetime of episodes. Now, you have an elder with a lifetime of bipolar disorder or schizophrenia, and now they begin to develop cognitive impairments. And we're in an era where we now have these anti-amyloid treatments on board. So do you accept that this could be that old story, which, by the way, no one is studying carefully today with modern methods. So you have this old story about people with major mental illness declining when they get to late life. You have the likelihood that the chronic mental illness has not immunized them from Alzheimer's disease or anything else. And then you have these modern treatments. What I would say is that generally speaking, firstly, the when it's Alzheimer's disease, the phenotype is more detailed. And so there's certain characteristics that make it easier to tell. Disorientation is one. Apraxia, losing basic skills, is another. And then you have the biomarkers if you either want to take a shortcut or if it's difficult to do clinically. It's trickier with late, but you would not expect focal hippocampal atrophy, for example, with any of these major psychiatric conditions. And you wouldn't even necessarily expect it predominantly amnesic syndrome. It's more likely to manifest as executive dysfunction. So there are some clinical aspects that can help you make the distinction. Ultimately, it can be difficult. What we have done is sometimes use FDG PET. We look at an MRI. If we are not sure and it's very mild, we can do serial neuropsychological testing over a 1 month to 18-month intervals to see what the trajectory of change is. And you can use MRI to benchmark the current structure of the brain so that you see atrophy down the road and are able to attribute it correctly. And FDG PET would be expected to be normal, generally speaking, if it's not neurodegenerative. Neurofilament light chain is something people have advocated in the literature. But as I mentioned earlier, it's too unreliable to hang your hat on that. But if you had a neuropsychological profile that was relatively flat over a, say, 2-year period, you have normal FDG PET scans, and you also have normal neurofilament light chain, we would typically conclude that this is not neurodegenerative and that it's more likely to be psychiatric.
Thank you so much.
Sure.
Thank you so much. I think in lieu of the time, we want to thank our speaker for coming. And certainly, if anyone has any follow-up questions, you can certainly put those in the chat and we could follow up with you, or email myself, jmarks@jhmi.edu, or Wendy, and we can follow up. But we appreciate your time and everyone, and thank you for sharing your expertise with us and learning something new today. Very interesting.
Thank you.
And we hope to have you back next year. You can give us an update.
Yes, we'll be delighted to. Thank you again, and have a wonderful weekend.
So we appreciate everyone attending. As a reminder, July 16th, we will be discussing the CMS Guide program. So you're welcome to join us then. If you'd like some other caregiving workshops, classes, please make sure you visit the Maryland Living Well website to sign up for registration. Thanks again, everyone.